of course.
Okay, so we continue with the troubleshooting part, because I think we had some interesting discussions, and then afterwards we can go to the remainder of the metallic stenting session. So we have a third case here, a patient with an uncovered self-expandable metal stent placed for a presumed inoperable gallbladder carcinoma. Diagnosis turned out to be incorrect, and there was a complete resolution after antibiotics in this patient. And we have an uncovered self-expandable metal stent in place for 6 weeks. So what would you do in this situation? Can you still remove it easily after 6 weeks of placements? Mariana, what do you think?
6 weeks, it's a bit long to try to start to remove it. This very nicely highlights the fact that you should really never put an uncovered SEMS if you don't have a clear diagnosis.
Yeah.
So this is very important because these stents, I'm sure that we can do some troubleshooting, we'll find solutions, but they're not so easy to retrieve like an uncovered the esophageal partially covered stent with the parts that are uncovered, that you can put a fully covered stent and have pressure induced necrosis and take it out. So a bit more complicated. So it's very important to avoid putting in uncovered SEMS if any doubt.
Okay.
I hope to show you the data next year.
Yeah, okay. Looking forward. So there is a technique described in these cases. So and you put a non-cutting wire in place through the meshes of the stents, and then bring it out and use the mechanical lithotripter, which we would use for emergency lithotripsy. And this was published in 2018. Here is video. So if you use this crushing device, then the stent will go into the metallic sheets of your crushing system. And we have used this technique a couple of times, and it's not always successful. I think it's mainly successful if the stent is not in place for that long. So here in this case, it was only 6 weeks. The stent was still in a good shape. The ingrowth was not that there was not that much ingrowth, so it was successful.
Yeah, I think it's important that you don't use longitudinal forces, that you don't just pull at it, because then it will break.
Yeah. That will never work if with an ingrown stent. If you use longitudinal force, you really have to have a sort of radial force to extract the stent.
And what's the practical approach with your guide wire? How do you fix it to the mechanical lithotripter?
So you bring both ends of the guide wire out of the patient, and then you put over a metallic sheet, and then there is a system where you can just turn on the wheel and then gradually push the stent into your metallic sheets.
We use that system for also the lap bands.
Yeah, it's
to
exactly
break
the
them.
same system.
So you really have a lot of cutting force with the wire.
Yeah.
But here you manage to use a combination of force, I would say, the radial force, to kind of like bring it out of the embedded mucosa and bring it inside. But probably, as you said, it won't work for a stent that's there for 1 year.
You also have a risk of acute cholecystitis if you close off the cystic duct. And of course, it's also important to remember that this is not for hilar use, because you risk occluding the side branches or even the contralateral hepatic ducts. Of course, there are some ways of bypassing this, but I think this is beyond the scope of the current talk. As for uncovered metal stents, what we sometimes hear from the old-timers is a full metal jacket stent. But what we mean with this is just a bare metal stents, and have a little bit of a other connotation with the Full Metal Jacket, one of my favorite movies. But in general, these are just bare metal stents with metal struts. They used to be iron and steel, but of course this has all been changed into platinum and nitinol stents. Advantages is that you can use them in hilar stenting because of the open struts on the side. They have a lower risk of cholecystitis because of this, and they are less prone to migration. And even after a couple of days or a week, these are nicely fixated into the bile duct. And here on the right, you see what happens sometimes with the high risk of ingrowth. You have a high risk of dysfunction over time. And what you see here on the lower right is ingrowth at the papillary region, and it's sometimes hard to treat these patients because they often come back and develop recurrent symptoms. So you can perform SEMS and stents placement or plastic stents or just clean it out, but this is the problem with uncovered SEMS in general. As for partially covered stents, that's something I learned from the presentation, that actually every company has its partially covered stents. But of course, the last few years, it's been predominantly the GIEQs stent that has won a lot of attention. And this is a partially covered stent and combines actually the properties of both uncovered and fully covered stents by the uncovered part that goes into the liver and prevents occlusion of side branches, and the covered part that prevents bile leakage when crossing the peritoneum and also the gastric wall. So this is a little bit of a all-in-one stent, and you see also the delivery device. And a placement you see here on the left on EOS, but the GIEQs stent again is only used for EOS guided hepatogastrostomy. And there are certainly some do's and don'ts during hepatogastrostomy, but I think that's just a little bit out of the scope for this ERCP session. So again, partially covered SEMS really combine the advantages and disadvantages of uncovered and fully covered stents by a low risk of migration. They just grow inside the bile duct and liver, and also a low risk of dysfunction because of the fully covered part. Again, disadvantages are that they grow in, so benign disease is a real contraindication, and of course the GIEQs stent is designed for EUS use only. I will not touch on this too long, just one slide. Pancreatic metal stents. Just this month, a nice systematic review has been published, including 19 studies by Andrea Tringali. And what they saw when they pulled all these results together with fully covered SEMS and pancreatic strictures is that they saw high stricture resolution in 91%, and also pain resolution in a high degree of patients, and stricture recurrence only in 6%, and that's quite the results. But what we also saw in this systematic review is that heterogeneity was substantial, and also only 4 studies had a low risk of bias. So I think we can conclude that there's definitely a place for more well-designed studies.
And then make sure that the SPY scope is in a straight position. And sometimes, if you really get stuck, you have to come back, or you have to. Sometimes you have to go in. Sometimes you have to go back to further advance the SPY bite, and sometimes also opening the SPY bite in the channel and then closing it again and pushing it forward can also help.
Yeah, sometimes we get blocked where the elevator is. And as you said, usually if you just push the whole SPY with your SPY bite inside, you pass that, you ride through the elevator curve, and then you can take out the SPY bite.
Yeah.
And I think also the role for the nurse is very important here.
Yeah, we have very, very skilled nurses, of course, are very...
yes, that's good when you don't have to say
very
anything.
lucky.
But you see it on the fluoroscopy, because they help you with the introducer. They retract it a little bit, and therefore your stent goes in more easily.
Yeah,
So,
absolutely, absolutely.
The nurse factor is in ERCP is
extremely
immeasurable.
Yeah.